Good morning and welcome to today's webinar, Medication for Opioid Use Disorder. Today's training is being offered by the Behavioral Health Quality Department and Behavioral Health Medical Directors and will be led by psychiatrist Dr. Brooke Parrish and licensed professional counselor Brooke Rowney Perez. If you have questions for the presenters during today's training, there will be a time at the end for questions. Please type your questions in the Q&A box. All right, we're about to get started. We'll pull up the slide deck and I will pass it over to Brooke.
Hi, good morning, everyone. Welcome to our CME today. Go ahead and hit next slide. Just some disclosure statements. Next slide. Learning objectives today. We're just going to talk a little bit first, kind of a general overview of opioid use disorder. We're going to talk about some medicines used in opioid replacement treatment. And then we're just going to talk about some interventions and treatment strategies and things to do with this population. So we'll go ahead and jump in and get started. So I'm going to talk with you guys a little bit about just an overview and then a few statistics. All right, so the DSM describes opioid use disorder as a problematic pattern of opioid use leading to problems or distress, with at least two of the following occurring within a 12-month period. And I'm not going to read all of these, but a few of the things that you might see are taking larger amounts of the drug or taking them over a longer period of time than intended. If you have a patient who's having cravings or strong desire to urge to continue to use the opioids, when they continue the opioid use despite having a lot of problems at school, at work, at home, socially, just interpersonally, if they're continuing opioid use despite ongoing physical problems or some mental health problems that it's exacerbating, they're continuing to use. Or if they're experiencing withdrawal or they're taking those opioids to relieve or avoid that withdrawal. So really, if you have a patient comes in who's exhibiting at least two of these and it's within that 12-month period, can definitely be considered to have opioid use disorder. And next slide. So the biggest risks for opioid use disorder, the top one is, the one that really is most people most familiar with, respiratory distress, because of that, of course, can lead to overdose, which can lead to brain damage or even death. So that's a huge risk when it comes to using these drugs. Other changes, other things that can come from using opioids, cardiovascular changes. So opioids can lead to a variety of heart problems, can be a little bit shorter term, like hypotension or bradycardia, but can also lead to longer term, more severe heart problems like heart attack or other heart failure. And then even if people are injecting opioids, that can lead to different heart infections like endocarditis. So just a lot of different ways that opioids can affect the heart. Impairment to immune system. So this as well, that again, there's a variety of ways that the opioid use can impact the immune system, but overall, it really suppresses our immune system and it can lead to opening people up for infection. So that's a big risk if you have patients also that are using. Leads to conditions, HIV, hepatitis C, they're much more likely to contract one of those. Hypogonadism, which is low level of testosterone. And then another thing that it can lead to, or that it's a big risk factor for, and we'll talk more about this throughout the presentation, is for pregnant women and their unborn children. And we'll touch more on this as we move through the presentation. All right, so a couple statistics around opioid use. So this chart that we're looking at is showing the number of deaths in the United States. It's pretty much over a 10-year span. You can see January 2015 through January 2024. And on the right-hand side, you'll see a legend, and that shows you which color lines are attributed to which drug class. You'll see that the very top line is opioids, the black line. And what we can see from the chart is you're looking at a steady increase when you start in 2015. We're under 40,000 at that point, climbing up to over 40,000 when you're hitting around 2018, kind of levels off. And then in 2020, we see a huge spike in the increase of deaths from opioid use disorder. We know in 2020 that we saw huge increases of substance abuse across the board. So this is not unusual or surprising that we saw this huge increase. So it really ticked up and kept going for a while. And then one positive note is that we are seeing, and when you look at kind of the end of 23 getting into 24, we're seeing that it starts to decline, the number of opioid deaths. However, still a very, very high number, still sitting around that 60,000 mark. So something important to know, just how many people we're losing every year to opioid use disorder. Next slide. And then I mentioned that we're going to touch more on opioid use in pregnancy. This has been linked to many different serious health outcomes for mom and for her child. It can lead to maternal mortality. It can lead to stillbirths, preterm births. It can lead to neonatal abstinence syndrome, where the child is born going through the withdrawal symptoms. And then a couple of statistics related to this. From 2010 to 2017, they saw a huge increase in the number of documented deliveries with women with opioid-related diagnosis. It increased by 131%. So that's a huge jump in that 7-year span. And then according to some of our 2020 data, there about one baby diagnosed every 24 minutes in the US with neonatal abstinence syndrome. So that's a huge number. That's a huge amount of mothers and babies being impacted with this. So again, it's a really important topic and something that Dr. Parrish will address as we get further into the presentation and about how to work with this population that is having opioid use disorder. So with that, I will turn it over to Dr. Parrish.
Good morning. I would like to start with how we currently treat opiate use disorder and with how opiates work. As mentioned, that opiates can affect a lot of the body system, and that is reason because the receptors are distributed not only throughout the brain, including the brainstem, thalamus, amygdala, and nucleus accumbens, but they're also throughout the peripheral nervous system and including other organ systems as well, such as the mu receptors, responsible for the analgesic effects and sort of the euphoria, and one of the aspects of addiction. But it is also in the GI tract, which they're responsible for that wonderful side effect we know as constipation and even obstipation with opiates. The kappa receptors, along with the delta receptors, are also within the immune system. As mentioned before, that opiates really can affect the immune system. And it's basically a downgrading of the immune system. Kappa also is seen in the kidneys, along with the lung and spleen and the heart. We're not 100% sure what they're doing in the lung and the spleen for the delta receptors. That we're still researching. However, for the kidneys, they can work as very mild diuretics with that delta receptor. Delta, or in the kappa receptor rather. In the delta receptor, it is again the GI and the heart, and some degree a little bit into the pancreas. Next slide. One of the things when you are looking at opiate use disorder is that medications are probably our strongest weapon against opiate use disorder. That certainly we're using medications, behavioral therapy, while an excellent adjunct and is probably necessary in terms of long-term change. In terms of the short-term, behavioral therapy really does not need to be required. You can start somebody on medications for opiate use disorder and have very good success in terms of changing their lives, and it really can be life-saving. and that the combination of medications and behavioral therapy is probably the most powerful. But if there's somebody that is not ready to go into behavioral therapy yet, that's okay. It is not a contraindication for starting them on medications, and those medications can be life-saving. Next slide, please. So what are the benefits of medications, also referred to as MAUD? Used to in the past be referred to MAT, as in for medication-assisted treatment, now medications for opiate use disorder. It's basically that it does reduce the risk. It reduces the risk of death, reduces the risk of returning to drug use, and allows people to get on with their lives. It can reduce or eliminate any withdrawal symptoms. That being said, most the medications, especially buprenorphine, you need to have started into withdrawal. We'll talk a little bit about that before you start buprenorphine. And for naltrexone, you need to be completely through withdrawal before starting naltrexone. It can reduce the cravings to use opiates, and really it can help people decide to move on with their lives and really get down into why they went into the opiate use disorder in the first place. It certainly reduces the risk for contracting HIV, hepatitis C, and other hepatitises. And again, it helps people get on with their lives. It allows them to start living their lives in terms of forming relationships and getting a job, etc. Next. So what are the medications for opiate use disorder? I've sort of hinted at them. One is methadone. This is our oldest. It is an agonist. Buprenorphine, also known as Suboxone, is a partial agonist, however, very strong binder. And then there is naltrexone, which is an antagonist. Next slide, please. One of the things I want to talk about is MME, and this is sort of how we set the equivalence of what opiate is stronger than the other. You'll occasionally see this. You'll also see this when you check the prescriber database in terms for your patients. You'll see an daily MME calculated up there, and it helps standardize the doses in terms of what all the strength of that opiate is. And it certainly can be used as a gauge for both abuse and along with potential for overdose for that particular opiate and in terms of the dosing. Next slide. So here's some common conversions. Methadone actually has 4 for oral and is 3 for IV. Suboxone is actually quite controversial in terms of what that strength actually is. The research number that is often touted, and again, somewhat controversial, is 30. And the reason for that is there's a ceiling effect. And one of the cool things about Suboxone is really it is quite difficult to, if not impossible, to overdose because there's a ceiling effect. Once you have all the receptors bind, there is no more binding that can happen. And so that is why Suboxone has much decreased respiratory risk. And in fact, the only respiratory risk that has really been found is when it's in combination with benzodiazepines. Next slide, please. So methadone, I'm going to start with the oldest, as I mentioned, in terms of the replacement therapies, and that is methadone. It is a very long-acting opiate. It reduces cravings, it reduces withdrawal, and it really blunts any effect because it blocks those effects because it's a stronger binder. Remember, it's 3,4 for the morphine equivalents. It is taken daily. It comes in multiple different forms. Now, the bad news is that it can really only be dispensed through certified opiate treatment programs. And that's for the daily use for opiate use disorder. It can be used by any prescriber holding a DEA for schedules 2 through 6. You must have the 2 for pain. If you're dosing it for pain, you'll dose it in lower but much more frequent dosing, often looking at TID, if not QID. And again, any prescriber holding a DEA can do that. Also, you can dose it for short periods of time for people that are inpatient, such as if you have somebody in the hospital that is on regular opiate dosing. Next slide, please. So things to know about methadone. Excuse me. Especially your patients, they should not take more than their prescribed amount. If they feel that some dose is not working, or if they missed a dose, they shouldn't take an extra dose. There are interactions in terms of respiratory depression with alcohol, benzodiazepines, muscle relaxants, other opiates, although remember it will block because it has a much stronger, most other opiates. Sleep medications. It also has a potential for prolonging QTC in terms of the heart conduction. And so other medications, especially antibiotics, looking at you, the ubiquitous Z-Pak, azithromycin, could lead to even further prolonged QTC, which of course leads to torsade de pointe, which obviously is a medical emergency. It does have some serotonin activity, and so medications that strongly increase serotonin, including SSRIs or SNRIs or MAOIs and tricyclists, really should be used with caution. Doesn't mean they can't be used, but again, needs to be used with caution to avoid serotonin syndrome. And then, of course, naltrexone will cause a precipitous withdrawal effect with it. If they are starting the medication or having a dose increase, there should be some caution in terms of driving. Once they're chronically on it, it is not an issue. They can go about their daily lives. And certainly there is a risk of overdose with methadone, and 911 should be called. It should be stored out of reach. Room temperature, this is not medication you want to put on your window in the southern window. And again, unused medications should be disposed of safely, as all medications should be. And certainly they should never share their medication. Next slide, please. So side effects. Restlessness, nausea, vomiting, slow breathing, constipation. Remember those kappa receptors, it does hit the kappa receptors. Some people will have some sexual problems. Again, the issues with hypogonadism. Some of the serious side effects, again, seen in overdose, some difficulty breathing or shallow breathing, especially in combination with other respiratory depressants. Some people, especially when starting or dose increases, may feel somewhat lightheaded. Allergic reactions, again, for most opiates, because remember, opiates are naturally occurring in our brains. Allergic reactions are incredibly rare, but occasionally will happen, especially to binders, dyes, etc. Chest pain, even fast pounding heartbeat, especially with perhaps prolonged QT, and especially if they have gotten in trouble with torsades. Very rarely will you have sort of hallucinations or confusions or a delirium with it. Next slide, please. Buprenorphine. Buprenorphine is a synthetic opiate, but it is only a partial agonist, and it really does not have the euphoria that is seen with opiates. So therefore, it has a much lower risk of dependence, both physical and psychological. It also has a ceiling effect, and so it's very difficult to overdose on buprenorphine and cause that respiratory depression. We have had a couple of deaths with it, but it is only in conjunction with the benzodiazepines, and those were very high dose benzodiazepines. So it can be used to treat both pain along with opiate use disorder. Um, and it really allows people to start living a normal life and perhaps even start therapy and work on the reasons for their opiate use disorder. It allows people to not experience withdrawals and to experience and spend their lives in their opiate use disorder as opposed to getting on with their life and living their life. So the effects in terms of the euphoria are much weaker, but again, it has that much, much stronger binding. It is actually considered safer than insulin. And remember, insulin is essentially over the counter. So again, this is a very safe medication, and I want to emphasize that. Furthermore, anybody that has a DEA 2 through 6 can prescribe this medication. In the past, there were fairly rigorous training requirements. Those have now gone, and it is all under the waiver. When you get your DEA, you sign that you have taken 8 hours of training. It does not have to be specifically in buprenorphine, but if you are interested, certainly there's 8 hours of training available. Most of the time, you can find it very inexpensively and for free in various spots. If you're interested in prescribing buprenorphine, one of the websites I would have you Google is SAMHSA, Suboxone Training, and you will find a myriad of technical trainings along with technical assistance for prescribing buprenorphine. Next slide, please. So some of the things to know about buprenorphine. A patient needs to be in a state of withdrawal. We're typically looking at probably around a COWS score of anywhere from 7 to 9 to start buprenorphine. If you start it too early, you can precipitate withdrawal, which obviously is very unpleasant. There have been a very few case reports of actually broken heart syndrome, Takasumi's syndrome with precipitated withdrawal when starting buprenorphine. That shouldn't scare you. It is only a couple case reports. Furthermore, those that are not in those early stages, again, it's that risk of withdrawal. The length of time for a patient to receive buprenorphine should be individualized. Generally, we are looking at buprenorphine in the long term. That is what has been shown that the patients do the best. And in some cases, treatment can be indefinite or lifetime. But again, it is very much should be looked at as a long-term medication. Next slide, please. Things to know about buprenorphine. Patients should really let their physicians know that they are on buprenorphine when they're consulting another physician. In particular, there are some side effects, again, as mentioned, or you can get into respiratory depression with high-dose benzodiazepines. They should really not use illegal drugs. Again, if they're using opiates on buprenorphine, they will find that they will not get much of an effect. However, drinking alcohol, taking benzos, again, can potentially cause the risk of respiratory depression. They should have liver issues monitored. However, again, looking at this, the risk benefit, even for those that do have some mild liver injury, really the risk benefit of having exposure to hepatitis, buprenorphine definitely is the lower risk. Certainly, they need to tell their doctors if they become pregnant or plan to become pregnant. It is not contraindicated at all. And in fact, the risk benefit for being on buprenorphine if you're pregnant versus the opiate use disorder is well understood that risk benefit is much more towards the buprenorphine. And again, patients should never share their medications. Next slide, please. So what are some of the buprenorphine side effects? Again, some people will have constipation, headaches, nausea, vomiting. This tends to be much lower than methadone or opiates by a long shot. Some people may have some dizziness or drowsiness, fatigue, sweating, dry mouth, muscle aches or cramps. Again, a lot of times this may be seen with precipitated withdrawal if it was started a little too early, inability to sleep, fever, dilated pupils, tremors, palpitations, disturbance in attention. Again, a lot of these are with the start, especially if started a little too early. Serious side effects, again, if combined with high dose alcohol or with a sedative, respiratory depression. Overdose, again, we're looking at that ceiling effect taken in and of itself. Very difficult to get into respiratory depression with buprenorphine alone. Potential adrenal insufficiency, dependence, withdrawal, itching, pain, swelling, nerve damage with the implants. Buprenorphine does come both in film, dissolvable tablets, along with an implant and a long-acting injection. Pain at injection sites. There have been a few cases that with the nerve damage, pain, swelling, that there have been some skin muscle necrosis that have required surgery. But again, this is incredibly rare. And neonatal abstinence syndrome in newborns. While this may look scary, I want to assure you that it is incredibly safe medication. Moving on to naltrexone. Naltrexone is an antagonist. So any prescriber, you do not need a DEA to prescribe naltrexone. It is not an opiate. It is not addictive. And it basically blocks the effects of opiates. It binds again to the mu, kappa, and delta receptors. It does not cause any withdrawal symptoms. However, it must be used after the patient is fully through acute detox. They're still having some issues with post-acute withdrawal syndrome. That is fine, but they must fully be through their detox. And it is available also as an extended release injectable for opiate use disorder. One of the cool things with naltrexone, it can also be used for alcohol use disorder as well. Next slide, please. So what are some of the things to know about naltrexone? It can be used for opiate along with alcohol use disorder. Certainly, it should not be used for anybody that is allergic to naltrexone or any of its binders. One of the things for current liver problems, we are looking for those that have liver enzymes 3 times more than normal. Probably should not be using naltrexone. It also has issues with platelets. So if you have hemophilia or other bleeding issues, this could also be a contraindication. One of the things to clinically take stock of if they are already on Plavix for either stroke or MI, that this could also be a consideration given some issues with the platelet binding. If they have chronic kidney issues, this also can be an issue. If you're pregnant or plan on becoming pregnant, again, those risk benefits must be sort of decided, or breastfeeding, again, those risks must be decided. One of the things that patients may say that they're completely off of all opiates, but not realize that many cough medications do contain codeine, and this is a issue and will cause a precipitated withdrawal. Also, many diarrheal medications also bind to kappa, or affect the kappa receptor, and this also can cause issues. And again, really knowing what all medications, vitamins, and herbal supplements they are, because many herbal supplements also cause issues with platelets and bleeding. Next slide, please. So what are some of the common side effects? Nausea. Some people have issues with insomnia, headache, dizziness, vomiting, decreased appetite, painful joints, muscle cramps, cold symptoms, trouble sleeping, and even occasionally toothache. Those are very interestingly rare, but it's reported. Serious reactions, again, site of injection. Again, there are a couple case reports that the injection site, if not done correctly, can cause tissue death, which surgery may be required. Again, very, very rare. And if not done with the proper technique, lumps or hardness, blisters or open wounds. That liver damage, again, looking for that 3 times more than normal over the liver enzymes. So any issues with the liver, if they have signs of liver damage, the yellow eyes, dark urine, tiredness, pain, especially in that right upper quadrant. There have been a few serious allergic reactions. Pneumonia, most likely aspiration pneumonia, and depressed mood. Next slide, please. So what about treatment of opiate use during pregnancy? Next slide. Opiate use during pregnancy. We know that opiate use during pregnancy really does put not one patient at risk, it puts 2 patients at risk, both for health issues for the baby, premature birth rather, low birth weight at birth, and what is called neonatal abstinent withdrawal syndrome, which irritability, crying, difficulty with bonding, which can cause problems both in childhood, throughout childhood, tremors, and poor feeding. So this is very much something that we wish to avoid, and certainly in cases of overdose with opiate use can cause the risk of death for both mom and baby. Next slide, please. So opiate use treatment during pregnancy. Gold standard is methadone. However, buprenorphine really now has a track record in pregnancy, and really that risk-benefit ratio really does tend towards treatment during pregnancy, be it with methadone, be it with buprenorphine. Medications are safe and effective for pregnant people. Naltrexone does not have quite the runway that methadone and naltrexone um, do for pregnant people. However, again, and especially one of the reasons for naltrexone is, remember, you have to fully go through withdrawal, and withdrawal during pregnancy really is one of those things that is to be avoided at all cost. So treatment really can help with the withdrawal symptoms, because again, remember, even buprenorphine, you want a little bit of withdrawal, but not much at all. And the amount to start induction with buprenorphine really has not been posed an issue. These medications really can help people get into and stay and get the other health care, the prenatal care that they need. Even nursing moms can continue with the methadone and buprenorphine. The amount in breast milk is quite small. And again, breastfeeding really can lessen the severity of the neonatal opiate withdrawal syndrome. So if you do have somebody that unfortunately did not get into care before birth, again, that does not necessarily preclude, if you choose to start them on buprenorphine or methadone, does not preclude them from breastfeeding. Next slide, please. Treatment should be offered as soon as possible. As soon as you find out they are pregnant and have an opiate use disorder, again, MAUD should be offered. Both methadone and morphine, as we've talked, are sort of that first line treatment in conjunction with behavioral health and medical services. Certainly, you do not need that behavioral health if they are not ready for it, and they can get that MAUD, which hopefully will get them into medical services and mental health services. Again, naltrexone may be used, especially if they're already on it, but again, that information is limited. And again, MAUD is considered typically a long-term treatment, and certainly during pregnancy, this is not the time that you would want to taper somebody off of MAUD. That this is one of those things that certainly better maternal and perinatal outcomes are expected if you continue with that opiate treatment. Thank you. Next slide. And I believe I am handing it back over to Brooke. Thank you very much.
Thank you, Dr. Parrish. So we'll talk a little bit about some treatment success strategies. The first thing, there is no one size fits all approach when it comes to OUD treatment. It's a very individualized thing, and what works with one patient may not work with the next patient. So it's really, really important to work with the patient and work around their lifestyle and their priorities and what they want to achieve with treatment. Discuss long-term use of medication for opioid use disorder. As Dr. Parrish mentioned, it's been shown in studies to be associated with positive outcomes for patients who stay on it long term. So definitely want to talk about that as an option with this patient population. You want to use terminology kind of in a couple ways. You want to use terminology that's medical and that it's neutral. You really want to focus on that person first language as well. And all of this, what does that look like? So a couple examples, terminology that's more medically neutral. Say you're referring to a urine sample. Instead of saying a clean or dirty sample, you would say a positive or a negative sample. Or say you have a patient who has not been attending to all of their treatment plan. Instead of calling them non-compliant or unmotivated, you may say not participating or choosing to disagree with their treatment. One big thing is when you're talking to patients in this population and their family members as well. So anybody that's there working with you and supporting that patient as well. You never want to use the terms addict or user. You want to use person with a substance use disorder or a person in recovery, something of that nature. Really, really important about how you talk with patients, for a variety of reasons. First, it emphasizes that, it's about the individual and the individual is not their diagnosis. So they're a person with substance use disorder, but that's not all they are. And we always want to highlight that. It reduces that stigmatization, that shame that they feel. And it's going to help you build a better relationship with your patients. Using terminology like that and approaching them in that manner and being sensitive is going to help you build a better relationship with your patients, which is going to lead to longer, better term, better outcomes. Every patient who misuses opioids or has an opioid use disorder, they should receive overdose prevention education and naloxone prescription and education. And this also goes for anyone living in the household or anyone supporting the member. Be great for anyone that the patient is using for a support system, but it really, really is important if anyone else in the household, adult is in the household, that they understand the education as well. Being able to use naloxone and having that education has helped prevent many, many deaths from overdose. So that's a really important piece. And then last on this slide is when you evaluate patients, they come in, maybe they're coming to see you, maybe a primary care physician, they're coming in for another physical issue. They've got high cholesterol or hypertension or something else going on. But they also have opioid use disorder or another mental health or substance use diagnosis. You want to make sure that you include that as part of the primary diagnosis and documentation. It's a really important thing for everyone to know who's treating this patient. So if the patient moves on from you or if the patient goes to see other treatment providers in conjunction with seeing you, those treatment providers, it's going to be important for them to know that about the patient, especially for something like OUD. That's always going to impact their treatment that they're receiving. So in order to foster that continuity of care, just always documenting that diagnosis is important. And next screen. Additionally, I talked about that individualized plan and collaborating with the patient. You always want to develop the treatment plan with the patient, and you want to base that on their priorities and their concerns. So whatever they have going on. So for example, you may think that the patient really needs some therapy. They could really benefit from some behavioral health therapy of some kind. But maybe that's not the patient's current priority. Maybe that's not the big focus right now. Maybe right now they really need to focus on maintaining the medication treatment. They need to focus on employment and getting just kind of their basic living down of how they're going to take care of themselves. So that may be their priority. They may not be ready for therapy. So it's important to note that. It's important to work with them and note that. And maybe therapy is something they could do down the line, but maybe today that's just not the priority in what they need to focus on. So really, really important to work collaboratively with them. Use the 5 A's at every visit. And those 5 A's: assess, advise, agree, assist, and arrange. Kind of an important note on that. It says every visit. So that's where when you see the patient at every follow-up that you have with the patient, you want to look at just a whole host of things. You want to talk with them and assess how are they doing with their substance use treatment. If they're doing the medication, how is that going? Are they having any outside substance use, illicit substance use? Any withdrawal symptoms, any side effects? Do they have any other mental health issues going on? Anything new that's popped up, mental health or physical? Do they have any physical issues, new things that have popped up? How are they doing? What's going on with them emotionally? What's going on with them with work, with school? What's going on with family? Do they have support? You want to look at those things every time. And even if you've seen them and you think that the history, we talked about that, the first appointment, we've been seeing each other for 4 months, so I don't really need to assess that. That's probably not likely. You probably do need to continue assessing that because things could have changed. They could have changed from just one visit to the next. Other parts of that are assessing like any barriers they have going on. Do they have anything that's keeping them from getting, if they're getting medication at the pharmacy, anything that's keeping them from getting to the pharmacy, like transportation or financial issues? Is there any barriers that you can assist with? And arranging. So always making sure to help arrange, make sure those follow-up appointments are set. Make sure that if they need follow-up with other providers, if they need a behavioral health therapist, or they need a psychiatrist, or they need a neurologist, that we're helping them get those appointments scheduled and everything arranged for them, because that will help ensure also that continuity of care. Linking them to community resources and support, helping, anything that may benefit them. Another important thing is involving, if you have anyone in your practice, involving expert patients, which may be like peer educators, recovery support assistants, involving them in the work, involving them with the patient. Maybe there's someone in your practice that does this, or maybe if not, you can refer them out to someone. But this group of people has really been shown to help this population. Being able to talk to someone with lived experience and work with him has really been shown to have a huge benefit for this population. All right, next slide. And then a few things just looking at overall harm reduction and harm reduction strategies when working with this population. You can use drug disposal bags and provide that for patients to safely dispose of excess opioids. The drug disposal bags contain activated charcoal, and that neutralizes the opioids, and then they can be safely disposed of. And studies have shown that patients who are given those drug disposal bags are more likely to dispose of those excess opioids, which is great. So that's one thing. Another is giving locking caps with combination. So locking caps with combinations can do a couple of things. First, if you have a patient who is having an impulsive moment and the day is going really badly and they just reach for pills and they want to pop one, things are going really bad, it's just kind of an impulsive thing, they've been doing really well in treatment. If they have a locking cap with combination, that may slow them down and give them time to like think about, okay, maybe I really don't want to do this. Maybe I need to go do something else. Maybe I need to call someone, or, use one of my other coping skills instead of taking this pill right now. So it may slow them down and prevent them from using. Another benefit is keeping other people out of those medications. So especially if you have any children in the house, it can keep them out of those medications and unable to open those. So those can be a huge help as well. Next slide. And then finally, on the harm reduction approaches, safe injection sites and clean needle programs. So overall, they've seen different studies that safe injection sites are associated with lower overdose mortality, those rates, which is great. They can also help teach users how to properly administer naloxone. So if the case comes that they need to give themselves naloxone, that can help teach them how to do that. One of the arguments against these harm reduction, these safe injection sites and clean needle programs, is that it will increase illegal drug use or it will increase crime in the area. But they've had a couple of programs running in Baltimore and New York, and they found no increase in illegal drug use or crime with the programs being present. So that's a really important thing. And so these are a couple of resources to note too when you work with this population and work a lot with this population. So. All right. Fine. All right. And so that wraps up that part of the presentation. These are some provider resources. You'll see on the left, there are some national resources listed. On the right-hand side, some state-specific resources based on where you're located. You'll be able to receive this deck and you can access some of these if you'd like more information. And then next slide is going to be just a list of sources used for the data and for the material in the presentation. If you're interested in researching or reading further, you can refer to this as well. And then next slide. And lastly, the next two slides have some different member or patient videos that you can share with your patients. They're short little videos that we've created that talk to members or patients about a host of things. There's a couple on here about substance use. There's one about opioids specifically. There's one about continuity of care for members or patients who have ER visits or inpatient hospital admissions, and how do they get follow-up. And the videos typically will provide some education about these topics, and then it'll give resources where patients can reach out and get help if they have issues with any of these things. So please feel free to share these with your patients. You could put them in flyers in your waiting rooms, put them in their discharge paperwork. Spanish captions are available. So just something that you may want to share with patients. And I think that, yeah, that concludes our presentation. Thank you.
Great.
I think it's
Thank you
time for
so much.
questions.
Thank you so much, Brooke and Dr.
Mhm.
Parrish. We did have one question in the chat around Dr. Parrish. This might be for you. When you were reviewing the MME conversions chart, there was a question about what about fentanyl?
Fentanyl, it depends on what form of fentanyl you are using. For the fentanyl patch, it is approximately 7 for their conversion number. The others, in terms of the spray or IV, is lower. Remember, fentanyl is dosed in micrograms, not milligrams. So, again, you would expect those to be lower. One of the interesting things about fentanyl is I would encourage you to actually look at the SAMHSA website along with some of the research papers. In terms of dosing for Suboxone, is they're looking at, sounds counterintuitive, but doing microdosing with fentanyl.
There is it sounds like some participants have experience with patients who aren't really using patches and finding other areas for injection.
Forms
Is yeah.
forms for fentanyl, or what
That
specifically?
they're not interested potentially in using patches. Don't know if there was more to the question.
That in terms of Suboxone, Suboxone comes in several different forms. So, and one of them is generally it's a sublingual film. And the cool thing with the film is because you can really dose it by cutting it. The other is that it does come in an implant, and then it also comes in a long-acting injectable. I The methadone has a patch, I believe. Now, Trexone comes as a long-acting injectable by the brand name Vivitrol, and it also comes as pills that you can take. The typical dose that you will see is 50 milligrams daily. Off-label, it is used in lower doses, but a lot of times for other indications.
There was another question is for those that are using heroin, is methadone considered a lifelong treatment?
Again, that's very individualized. For some, either methadone or Suboxone will be a lifelong treatment. And it really doesn't matter what the source drug was. Was it heroin? Was it pills? Was it, fentanyl in any of its forms? Um, it can be. And for some people, that is the correct choice. For other people, it can eventually they can taper off. Um, However, it is quite individualized. It should be long-term treatment. This is not, research has shown that, really we're looking long-term. We're not looking for, this is a quick detox and then behavioral. Some people that will work, some people they're very motivated for that. The research shows the best with long-term.
Thank you, Dr. Parrish. Just go back here. Um, don't see other questions coming in the chat right now, but I just wanted to thank you all for attending today, and thank you, Dr. Parrish and Brooke, for all the information. Um, for those that have attended today, you will receive an email link to complete an evaluation and attestation for today's webinar so that you can earn your CME and CEU credit. You'll receive that email link after 24 hours from this presentation ending today. You would go out to the site, you'll complete those 2 items, and then you'll receive that credit. Also, if you would like a copy of the slide deck, you can download a copy at the same site that you receive your CME and CEU, and the same site that you registered at. Just with that, we will conclude today's presentation, and thank you all again.
Thank you.